Okay, well, good morning, everybody. My name is Vince Blazer, and I am the Senior Advocacy and Policy Advisor at IntraHealth International and Director of the Frontline Health Workers Coalition Secretariat in Washington, D.C. Thank you, everybody, for joining us this morning, this afternoon, this evening, all around the world. We really appreciate it. About a year ago, we released a report, IntraHealth International, Nursing Now, the Nursing Now campaign, and Johnson & Johnson released a report that spotlighted a survey of nurses from around the world, more than 2,500 nurses from 117 countries, where we asked them some of their perspectives and experiences on nursing leadership and some of the gender-related issues in nursing. And we spotlighted that in the 2019 report, Investing in the Power of Nurse Leadership, What Will It Take? And that report detailed, has a lot of great detail. We encourage those who haven't read it to look at, as well as spotlight some recommendations for policy and implementation change as a result of the responses that we got from nurses around the world. This is the second webinar in a series of the second and final webinar in a series, taking a little bit of a deeper look at the issues raised in that report. The first webinar, which is linked into the event page for this webinar, took a real deeper dive at what the findings of that report are. So we encourage those who haven't viewed that webinar to take a look at it. In this second webinar, we were going to take a look at some particular experiences and dive deeper into some of the issues raised in the report. Of course, since the first webinar, we've had quite a bit happen to all of us around the world. The COVID-19 pandemic is dominating everything that we're doing in public health. And especially in nursing, the first ever State of the World's Nursing Report was released in April, and of course, 2020 we have the International Year of the Nurse and Year of the Midwife ongoing, and so today we are we're very lucky to have with us colleagues from. In nursing and nurse policy leadership from China, from Kenya, and from the World Health Organization to detail a little bit of how the COVID-19 pandemic has affected their work, and specifically on leadership issues and on gender-related issues. And so we're really looking forward to hearing from them today. Just one bit of housekeeping before we get formally started here. We are going to take questions from our speakers today, but we will be taking them in the chat. So you will see the chat function at the bottom of your screen. You can put in questions or comments via the Q&A function or the chat function at the bottom of your screen, and I will monitor that throughout. Please feel free to share comments and other resources in the chat throughout the presentations. We will take as many questions as we can at one time after our colleagues from China, Kenya, and WHO present, and then we will end with some perspectives on what we heard from the gender-related perspective from Candy Newman at IntraHealth, and from the nursing leadership perspective from Howard Catton at ICN. So I am now going to turn it over to Barbara Stillwell, Executive Director of the Nursing Now 2020 campaign, and for official introduction. So Barbara, over to you.
Thanks so much, Vince. As Vince said, I'm the Executive Director of the Nursing Now campaign, and I'm based in the UK. So good afternoon from us here, and good morning, good evening, wherever you are. We're very pleased to have such a great lineup to talk about nursing leadership and gender, which is a really critical subject. As Vince said, we did a very comprehensive survey last year with IntraHealth and ICN and Johnson & Johnson. And we had great responses from around the world. We found that nursing is indeed a gendered occupation, and this was echoed in State of the World's Nursing Report, which found that 90% of nurses around the world are women. What we're interested in looking at is how that affects women as leaders, women who are nurses becoming leaders. And in a previous study for Nursing Now, we also found that nurses often feel that they're invisible. And indeed, in the latest awful COVID-19 outbreak, although nurses have been present at every step of care, from testing through to palliative care, for mental health care, although they've been present at every part of the care chain, they're often not present at high-level briefings, on the news. You know, it's usually doctors who are interviewed and featured on the news, not so much nurses, at least not in the UK and in some of the other coverage that I've seen. So does this matter? I mean, why are we thinking about this? Why are we so concerned about it? We would love the nursing workforce to be representative of the total population. And one of the reasons we suspect it may not be, i.e. it's mostly women, is that in many places it's still not viewed as a scientific problem-solving profession that relies on a real in-depth knowledge of science and an art to apply that science in person-centered care. And that's our concern. We want to know, how can we make that more visible, more valued, and help nurses who often step up to places where there are no other sorts of care? How can we raise the profile of those nurses and the status of nurses that goes beyond applause, which everybody's been very happy to have around the world during these terrible times. I mean, it's wonderful to have a round of applause. We're not all concert pianists, and when we leave, you know, there's a wonderful round of applause. So it's great to get that. But looking beyond that, nurses need good pay, good conditions, decent working conditions, respect, and an ability to contribute to formulating health policy. So those are the things that we're looking at, and why we think it's very important to look at the role of nurses as women around the world. Although we, of course, you know, great deal of respect and kudos to our men colleagues. It's by no means being negative about them, but saying we need to look particularly at women in leadership in this particular context. So there are three things I thought I'd highlight that really show how the gendered response has affected the way that nurses are seen in this pandemic. The first one I've mentioned, it's how visible nurses are. They have not been incredibly visible here in the UK until actually our Prime Minister mentioned them and said, you know, how much he appreciated the nursing care he'd been given in St. Thomas's Hospital, which was wonderful and very well deserved for that wonderful hospital. Ironically, it was the fact that the Prime Minister was put into intensive care on the day the State of the World's Nursing Report was launched that meant that we nurses were actually bumped from the news on the BBC. So we were seen as both, you know, within 24 hours, incredibly important and not important at all. So you kind of got to wonder, you know, when nursing is in this visibility visibility table. So one of the results of this, I think, is that nurses are often not integral to the development of health policy. And when it comes to public health policy, nurses are incredibly knowledgeable about community health, public health, and about formulating policy that will promote the health of the public. And yet, often we're not included, we're not integral to that. So that's the first area I want to highlight. Why are we not? How can we get more visibility at the policy tables and be included in formulating those policies? The second one is that one of the things our survey highlighted was that women nurses often have additional carer responsibilities for children, families, parents, and so on. It was the case here in the UK, and maybe where you are too, that many nurses actually had to move out of their family home and go and live in hospital so that they wouldn't be taking the infection back home with them, or doing any transfer of the virus. And this is very hard for nurses, and they were mostly, at least reported, mostly women. So we want to look at the gender transformative policies that will be sensitive to some of these carer responsibilities that nurses have. What do they need to be? How can we formulate them? How can we feed into policy formulation so that our voice is heard in these very particular circumstances? Another finding of our report that also I think is very relevant to what we're talking about today is that many nurses said they didn't feel comfortable speaking in a room full of men or at a high-level meeting. They didn't feel comfortable presenting data. And that's something else that we really want to address, so we get our voices heard where they need to be heard at policy level. And so suggestions you might have for how we do that, or your experience in that, would be extremely valuable. The final thing is very practical, but it's the provision of PPE, and it really, that's protective personal equipment. It links across all of these things. First of all, most PPE has been made for and measured around men. And for many women nurses, it simply didn't fit. It wasn't adequate. Now that has to change. We have to get our voices into that very practical arena so that our equipment, our working conditions are suitable for us. And it also means we need to find those ways of making those data available to the people who need to know in order that we can change the situation. So we need to move from being silent in those situations, and I don't think many of us have been in this one, to being very vocal. So those are the things I want to highlight from our report that I think are relevant to what we're talking about today, to the pandemic response. And I'd love to get your feedback and questions and ideas about those things, and indeed anything else in the report that you feel is relevant. In the chat box, there's a link to the report, so please do go and look at it. But now, I want to introduce you to my colleague from China, Linda Zhu. Linda, could you put your video and, if you can, your mic on? Lovely, lovely. So Linda is the director of program coordination for the China Medical Board, and Linda and I met when I was in China. I think it was 2018. It seems like yesterday, Linda, but I think it was 2018, wasn't it?
We'll meet again at a later time.
I hope. Yeah. Linda was a wonderful host while I was there, and actually took me shopping too. We had a really good time. So Linda, we're so delighted you can join, and you and your colleagues there have been doing some very important work about on the outbreak, and specifically in Wuhan. And I want to ask you to talk about some of the key lessons you've learned and the role and leadership of nurses in that emergency, and what we can learn from that about preparing nurses for the future.
Sure. Yes. Well, thank you, Barbara, and thank you, colleagues. About the Chinese nurses, they did a fantastic job in coping with the COVID-19. As you may know that China adopted a whole of government and whole of society approach in tackling COVID-19, including massive public health efforts and hospital-based measures led by doctors and nurses. And nurses played a crucial role in this holistic approach, as demonstrated in the external medical aid teams to help Wuhan, the epicenter in China. And first, nurses provided professional nursing care. They are nurses first, and it included the medical part, such as life support, symptom management, and nutrition, the public health part, such as health education, but also the social and psychological part. All were important to save lives. And second, nurses protected all health workers and patients, because nurses are leaders of infection control. It was the nurse who developed infection control guidelines, trained all health workers, and supervised them to make sure the rules were followed. And third, nurses assumed senior managerial role in leading special task teams in response to COVID-19. And for instance, in Peking Uni Medical College Hospital, the top Chinese medical hospital, among head of the 6 special task groups, 5 were nurses, and they were fully delegated by the hospital leadership, were held accountable, followed, and respected. So really, so in summary, in coping with COVID-19, the nurses provide nursing care and protect people with their skills in infection control, and also they played the senior management role in leading the response from the hospital level. Yeah. I cannot hear you, Barbara.
Sorry. Were there any barriers or challenges to nurse leadership, do you think? Did your colleagues find? Or was it assumed they would play a leadership role?
Yeah. Since most of our colleagues are from the top level Chinese hospitals, so their management concept or their managerial is really fairly advanced. In developing the response strategies, the chief nurses from the hospitals, they participated actively in the policy-making process. And what the nurses may need include their managerial skills. If we do capacity building in their managerial skills, that could help them to assume more effective leadership role.
That's very interesting. Yes, very interesting. And maybe, we don't pay enough attention to that preparation. And you might not need it all the time, but if there's an emergency, for example, we all need to be able to step up. Do you think that the response of nurses during the pandemic, do you think it's changed the perception of the public or of your medical colleagues about nursing?
Sure. Yeah, that is recognized by the whole society. And the President of China, President Xi Jinping, recognized contributions and professionalism of nurses on the mainstream public media. And anecdotes of frontline doctors and nurses were publicized on the TV and on the media every day. And doctors and nurses were recognized as heroes and heroines during the pandemic. And also efforts from the WHO, the ICN, and the Nursing Now have successfully mobilized the international momentum. So really, during the pandemic, the profile is really high, and people recognize nurses and doctors. Yeah, we hope that momentum can keep.
Yeah, that's really interesting. Do you have, in China, do you have enough people coming into nursing generally, do you know?
Actually, yeah, actually there is a nursing staffing shortage.
Yeah, be interesting. In England, the number of people applying to go into nursing has gone up by 150% this year. And we think it's because of the, the visibility of nurses during this pandemic. So I was interested to know if maybe that happened.
That will be an interesting survey. And we are going to have a better understanding after June, because June is the time for the college entrance examination. So we'll get to know that better. So to see if more students get enrolled and apply to the medical department and the nursing department.
Right, and yes, I think it shows really how timely the State of the World's Nursing Report is, because we have those data, reported from the countries around the world, and we can look at the National Health Workforce accounts and see if the number of nurses is going up, which would be an interesting unintended consequence, I think, wouldn't it, from the response. Linda, thank you so much for sharing that with us. It's so valuable and for us to hear from our colleagues. And there is a paper published on this, which we can share the link to, I think, can't we? Eventually. It's in the BMJ.
Thank you.
Yeah, thank you, Linda. So Vince, I think it's over to you.
Thank you so much, Linda, and thank you so much, Barbara. It's fascinating to hear the some of the early experiences from China and specifically Wuhan, and I think that's it's very valuable as the pandemic really is really just escalating in a lot of settings, to kind of hear the experience and learn from the experiences of nurses and nurse leaders in Wuhan, and apply those and hope to what we're doing now, what other countries are doing. So I'm going to ask Dr. Mary Nandili to start her video, and she is going to present next. Dr. Nandili is the Director of Nursing Services at the Kenya Ministry of Health. I will note before I introduce her that just this morning, IntraHealth, Nursing Now and Johnson & Johnson released a new brief in which in February we interviewed 29 nurses, nurse leaders, and nursing students in many different settings throughout Kenya, to get their views on some of these issues and some of as they apply specifically to Kenya. And so it is really some fascinating responses, and much in the same line of a little of what we heard from some of our colleagues in China. But those interviews were done in February, ahead of any cases of COVID-19 in Kenya. Obviously, the situation has changed there quite a bit in Kenya. So look forward to hearing from Dr. Nandili a little bit more about how the pandemic has affected nursing in particular and nursing leadership, and her thoughts on some of the issues that we need to address on leadership and gender in nursing. So Dr. Nandili, I will turn it over to you.
Thank you very much and welcome all of you. I'm delighted to speak with you, and I'm happy that you have all been safe And it's a great pleasure for us to meet once more, though virtual. Thank you. This is a follow-up of the interviews that you came over to Kenya, and unfortunately everything got disrupted because of this COVID, but all in all, we are all working well, and I'll give a slight presentation on the areas that I'm supposed to focus on. That is the impact of COVID-19 to particularly affecting nurses, leadership, nurses in leadership. One thing I should share with you first of all is to say gender is a challenge in Africa. The social and cultural rules and behavior patterns associated with the males and females is a bit challenging in our country. And it's quite unfortunate that the gains we have made in the past are at risk of being rolled back by the pandemic. This pandemic has deepened pre-existing inequalities. Both males and females are deeply affected. All groups are quite vulnerable and are exposed to social, economic, and security systems. From the reports we have, more males have been affected by COVID-19 disease as compared to females in Kenya. And we seem to be losing more males to the disease than females, which means the impact of COVID will lead to many women getting widowed, and as well, our our birth rates will increase tremendously. Women and males are locked at home. There is a lot of many gender violence cases increasing exponentially. Why? It's because people are restricted in their homes, they don't move, and therefore the women have succumbed to the sufferings in the hands of their husbands. Women are also hardest hit as they are busy with, most of them, they have small scale businesses across the countries. And therefore their economic status has been affected, leading to, we foresee a lot of many women running into poverty. And also this will affect the young, and it will also extend to the male, because the males now are more sick and they are not able to provide. When it comes to leadership, males are still predominant in decision making. Culturally, men are perceived as leaders and given the mandate for making decisions. Although behavioral characteristics is influenced by cultural environment all along. Females tend to be discriminated in our country, especially when it comes to awarding of top positions in leadership. Over 60% of nursing profession is dominated by women, yet most of them are not well represented in decision-making levels. Female nurses, on the other hand, double their effort with domestic matters, yet men contain their concentration at work. The pandemic has led to nurses being stigmatized. They are discriminated by their neighbors because of having conducted contact with COVID patients. They have been separated with their families. They are confined in an institution and hardly meet with their families. The risk of them contracting infection is high, as they are with patients longer hours. When we come to policy formulating strategies and policies, we need policies and strategies to address the inequalities in terms of leadership and also in terms of gender. An influx of male applicants in nursing leadership could help create pressure to expand nursing programs. If nursing becomes more diverse, it could become a greater force for social and public policy change. Holding regular nursing consultative forums for the nurse leadership is quite important, and this should be reflected in our policies and strategies. Advocate for nurses to be appointed in leadership and political positions to enable those in leadership level articulate nursing-related matters. All those should appear in our policies and strategies so that we make nursing a more vibrant profession. More males should be recruited in nursing field and be given or compete leadership positions to give other voice for their colleagues. Introduce gender transformative policies that would neutralize female-male dominance. To address behavioral characteristics as influenced by cultural environment where male think they are suitable rulers and leaders. All those should be we should ensure we have policies to guide that so that we are protected as nurses and as a profession. Potential impact on leadership. There is that when we have nurse leaders in top level positions, there would be improved care and services in our health facilities. And there will also be proper utilization of resources when we have nurse leaders, especially at the decision-making level. We also expect improved health outcomes, staff motivation and satisfaction, staff retention leading to reduced burnout. Because at the moment, we are short of nurses and our cases are increasing day by day. Today, we are at least we are recording about 124, yesterday 123. So the cases are increasing day by day. Our facilities are flooded with patients, and we are thinking beyond hosting these patients in a facility and probably mount tents that are spacious enough to enable our healthcare workers take care of patients. So economic outcome, a healthy nation is a productive nation. Economic impact is felt by women and girls. Hence, nursing is dominated by women. And therefore, if they are given a good package, of which I should attest to that, our president announced a month ago that is increasing a package for the nurses, not only nurses, but all healthcare workers. I think that was an added value to us, and it's a motivative factor of which has really given nurses the morale to work and provide service diligently. What do we do as a profession, as leaders? We need to allocate adequate finances to the profession and ensure that nurses control a portion of those finances. Policies, we come up with policies that govern nursing profession so that at least our voices can be heard. Top leadership support, we need leaders who are beyond us to support the profession. The political wing, we need to engage them in our meetings, in our discussions, so that they can keep backing us and supporting the profession. Indeed, I've done that because the cabinet secretary is working closely with me to support the nursing profession. And I'm delighted that he is with the nurses. During the pandemic, we need to support local manufacturers, small-scale businesses. We have nurses who are doing small-scale businesses when they are on vacation and when they are off duty. We need to support our own local manufacturers, our own small-scale business holders, so that at least this can help improve the economy. As we speak now, we are heading towards a very difficult situation whereby we are seeing all of us going down economically, and it will reach the post-pandemic outcome will be quite serious, especially in African setting. I'm looking at Kenya. When I look at Kenya, I'm looking at Uganda, I'm looking at Zimbabwe, I'm looking at the countries within the African region. Most small-scale businesses are done by women, and therefore this will build a healthy society. Thank you. Hello.
Thank you very much, Dr. Nandili. That was fascinating. You know, some reasons for hope and a lot of reasons for concern that we want to keep monitoring, and we really do appreciate you sharing those experiences and hope that we can continue to stay in touch and push on some of these changes that you outlined in your presentation. So thank you very much. As we continue on with so many great comments already in the chat and in the Q&A. Again, I will get to several of these and put them to our panelists after the next speaker, but also encourage folks to continue to directly continue the conversation with each other on the chat box, and because there are some really great experiences and comments being shared there. So our final primary speaker of today is Elizabeth Iro. Many of you know Elizabeth Iro is appointed the Chief Nursing Officer of the World Health Organization in January of 2018. Previously, the Health Secretary of the Cook Islands. Elizabeth obviously has been quite busy this past year with the first ever State of the World's Nursing Report and the Year of the Nurse and the Year of the Midwife. And then obviously so much of what we've already started to talk about in terms of nursing and nursing experiences in the COVID-19 pandemic. So I will turn it over to Elizabeth to share a little bit of her perspectives on how COVID-19 is affecting the nursing profession and particularly issues that we should be paying attention to in terms of nurse leadership and some of the gender-related issues that have been shared by nurses around the world. So Elizabeth, if I could ask you to go ahead and put on your video, and I will turn it over to you.
Thank you, Vince. I think, you know, what's happening right now is we are definitely at a very critical period, and how and what is prioritized and progress with the available data and evidence and the experience and the lessons learned prior to COVID-19 and during COVID-19 crisis can determine how rapidly we accelerate our contributions to universal health coverage and the Sustainable Development Goals. For our discussion today, I've kind of just looked at the investment in nursing leadership, decent jobs, and gender-sensitive nursing workforce policies, which were among 10 of the identified recommendations of the first State of the World's Nursing Report. So there's a whole range of policy options identified in the report that can support countries in terms of moving priorities and needs within their countries to a level that makes better health outcomes and for the people as well as for the providers of service. You know, the findings of this State of the World's Nursing Report were not too dissimilar to the findings from the IntraHealth and Nursing Now and Johnson & Johnson report, Investing in the Power of Nursing Leadership, What Will It Take? As well as the WHO Global Health Workforce Network and the Women in Global Health report titled Delivered by Women, Led by Men. You know, they acknowledge the important role of women in health, which is often, as I think Barbara mentioned, overlooked, and how the gender inequality in health will have constraints on the delivery of universal health coverage and health for all. Now, prior to COVID-19, we identified the issues that was mentioned by some previous speakers. You know, for me, shortage of nurses were one of the key ones, and the need for decent and safe working environments with better pay. And the third one was around allowing nurses to practice to their full scope of their license. And this all really calls for leadership development for nurses. COVID-19 has definitely put a spotlight on nursing and on these gaps that I mentioned. Staff shortage has limited our ability to respond to health emergencies. We saw this with COVID-19. We saw countries resolve to recruit retired nurses and final year nursing students. These were existing gaps. We need to have a better strategy before the next pandemic arises. But we need to have the strategy that actually sustains the profession and that sustains better health for all without a crisis situation. We have seen the lack of disproportionate distribution and use of resources for nurses during this crisis. Now, is this a reflection on the lack of leadership at the decision-making level? I think it is. Now, according to the State of the World's Nursing Report, 90% of nursing workforce is female, and 59% of the health professions are nurses. This is a really interesting statistic because, you know, as Barbara mentioned, it's a highly gendered profession, but it comes with its associated biases in the workplace. And these are some of the makes it very challenging for policy changes or policy shifts within countries. Because it also, as you realize, nurses are highly represented on the front line during a pandemic response. It places them obviously at the higher risk of frequent exposure to infected patients and the virus. But you know, yet there is limited availability of sex and age disaggregated data on this, therefore limiting the gendered implications for COVID-19 and the development of appropriate responses. Although we do have some anecdotal reports from countries that informs us on the infection rates and the fatalities. We must ensure that sex and age disaggregated data on nurses infected with COVID-19 and fatalities is collated and adequate measures put into place to safeguard their health. Employers have an obligation to ensure nurses have equitable access to training, PPE, other essential products to psychosocial support and social protection, taking into account the specific needs of women. We know that nursing opens up opportunity for women's participation in the labor market and helps promote gender equity, and it contributes to the economic development. But we need to retain nurses in the workplace, and this calls for the maintaining of their health and well-being. The challenge for us is how to elevate these issues to policy shifts that impacts positively, not just for nurses, but more so for patients, better health outcomes now and in the long term. I think it's really important that we take the lens of the wider and broader agenda for nurses, which is the better patient health outcomes because of the work that we do. It calls for the investment in nursing leadership, This means more jobs with decent work conditions, and this will require additional financial resourcing. And we must emphasize the returns to society and the economies when measured in terms of improved health outcomes, the creation of qualified employment opportunities, particularly for women and youth, and of course, improved global health securities. We've experienced this, and the previous speakers have talked to this experience. What we have witnessed during this crisis is the implications of the shortage of staff and resources, and the increasing social tension results, which gives rise to violence, threats, and aggression towards nurses and healthcare workers. We've had some positive responses from general public. We've had some negative responses in the way that nurses and healthcare workers are being mistreated. The World Health Organization calls upon governments, employers, and workers' organizations to establish measures for zero tolerance to violence against health workers at the workplace, and to intensify social support and respect for health workers. Nursing shortage coupled with long working hours, shift work, high workload, and other psychosocial hazards we saw can lead to fatigue, to occupational burnout, to increased psychological distress, or declining mental health. We've heard these experiences being shared, affecting the health of nurses and other health workers, and the quality and safety of care is compromised. This has been exaggerated or exacerbated during the emergencies as seen during this pandemic. The World Health Organization had called for adequate staffing levels and clinical rotation in healthcare facilities, measures to minimize psychosocial hazards, and provisions of access to mental health and psychosocial support for health workers. An investment in nursing leadership in a functioning role and responsibility is critical for addressing many key areas identified affecting staff shortage, decent work conditions, improved training and education, and that has potential to impact on better health outcomes for patients. Nurses must be engaged and involved in decision-making at national and organizational levels in the designing and development and distribution of resources, equipment, policies, and practice for better health outcomes for people they care for and the care providers as well. Throughout this, we have witnessed a strengthening of global nursing and midwifery communities through collaboration and the amplifying of key messages and contributions to better health outcomes for people and healthcare providers. We have seen some recognition of nurses from governments and heads of state. We heard two previous speakers speak to this. But you know, this is fantastic, but we need to follow these up with real commitments and policy changes. This is the moment, please, we must take action and follow these up. A nursing workforce for the 21st century must have gender-sensitive policies. These policies must consider how to ensure enabling work environments for women, for example, through flexible and manageable working hours that accommodate the changing needs of nurses as women, and gender transformative leadership development opportunities for women and youth in the nursing workforce. Everything we do during and after the COVID-19 crisis must aim to build more equal, inclusive, and sustainable economies and societies. This pandemic, as with many more before, have seen nurses play a central role in responses, but have usually been sidelined following a crisis. We need to ensure we do not miss this opportunity now to impact on policy changes. We need to have nurses at the decision-making level. Let us use the data and the evidence and the commitment of our leaders to make the change. World Health Organization have been working in collaboration with key nursing and midwifery partners to maximize on the significance of the year of the nurse and the midwife, to leverage what more could be achieved, and especially during this COVID crisis, for the immediate and the long term. We have to take a wider approach and look to leverage for the health workforce with a specific focus, of course, on nurses and midwives. In a couple of weeks, we will have the opportunity to engage with nursing and midwifery leaders from many countries at a meeting hosted by WHO, ICN and ICM, with an agenda that considers some of the issues highlighted and the opportunity for policy dialogue and how to support countries to use their data and the evidence in the context of their country health needs and priorities. This needs to be addressed through policy changes, and the time is now. Thank you.
Thank you, Elizabeth, for all of that. That was quite amazing, and some really great information shared. And of course, as you say, there's so much work to be done, and with all that has gone into building these advocacy campaigns, and I join you in calling for folks to utilize that to really truly push for some of these both policy changes as well as structural and implementation changes that are going to be needed for nurses to truly have for us to truly maximize the impact that nurses can have, not just for health outcomes in our society, but in truly kind of transforming our society. I know that the WHO has done extensive research on how nursing and other frontline health workers can foster economic growth and address poverty and so many issues. So really, many thanks for that. We are now. I'm going to now moderate a bit of Q&A with our participants. I think that there's been so many great pieces shared in the chat and in the Q&A. There's one question that I could maybe turn first back to Elizabeth, and then maybe to Linda and Barbara and anybody else, Mary, who want to join in, specific to COVID. And the question was, sorry, I'm bringing it up right now. Knowing that there has been, Anne Malua asked, knowing that there's been many reported recoveries from COVID-19, do we have any good documented evidence on the nursing care and what works? And on that question too, maybe also could, if Howard Catton, the president of ICN, has anything to add, he is our closer for today. Maybe Barbara, do you want to start, and then others can chime in on that?
Sure, thanks, Vince. It's a great question. And the first paper I'd point you to would be Linda and colleagues' paper, which was in the BMJ, which talked about, what the nurse's role was and how pivotal it was. I think it's going to take us a while to really compile the evidence, but we can see where nurses are, as I said in the introduction, along the care chain. So here in the UK, and maybe where you are, nurses do the testing. They also work for people who are admitted in A&E. They work in the ICU, on the wards, recovery wards. They work for people during end-of-life care, and it's been very critical because people have been cut off from their families. And I think coming up, there's going to be a lot more work on mental health, both for patients and for nurses who have been, and physicians, other health workers, being closely involved in the pandemic. So we can see, just by observation, that nurses are critical at every level of this pandemic. And I think what we need to start doing is, as they've done in China, is looking at different outcomes. So Linda will perhaps be able to talk more about that, but I noted from her paper that there were no reported cases of infections in nurses having looked after the patients, which speaks to the critical role nurses have in preventing infection from spreading. And that's always been true. And my colleague Alison Leary in the UK would say that, that the absence of infection is a sign of good nursing. So, you know, these are the things we need to be taking hold of and doing more investigation about. Over to you, Viv.
Thank you, Barbara. Linda, do you have something to add there?
Yeah, thank you. Yeah, first we acknowledge that there are far less research and papers from the nurses on nursing than compared with the research and papers on biomedical and the basic science and from the clinical science. So that is one thing we have to acknowledge. And also the evidence base, we didn't really actually look specifically into that over the last 2 months. But in the nursing paper, my colleagues and I co-authored, we did say that among the 42,000 external medical supporters, there is 0 infection. The reasons we think is that the proper personal protection and the roles nurses played in ensure the PPEs, the infection control measures were strictly followed and the PPEs were used properly. So we attribute the result of the 0 infection to the role nurses played in infection control. Thank you.
Thank you very much. Next, kind of a general topic. There are several questions asked in how and panelist recommendations. Oh, sorry. Go ahead, Mary. Yes.
Okay, sorry. Lessons learned from this discussion. I think I've picked up something that I'll try to see how to prepare a nursing care document for COVID patients. I'll go ahead and prepare something of the sort to support our nursing care during this pandemic time. I've also learned that nurses are doing testing. That is something that we are not doing here, and it's a good sign because now that COVID-19 has rolled to the counties, to the communities, I believe if I introduce that to the team, in a meeting, we can be able also to see how to engage nurses in testing, especially in rural settings, extreme rural areas. I think those are some of the lessons that I've learned from the previous speakers. The other thing is we nurses work across the board. In all the wards, ICU and infection prevention control has been really done well together with the measures that have been put in place by the government. And good enough, I've also directly been working with the Office of the Minister, whereby I participate in preparing a daily brief statement and any concerns that we need as nurses. I always I always convince the team, discuss with the team, and it's included in our daily press briefing. The critical role of nursing to prevent transmission of infection has been felt in the country, in the sense that we have had few fatalities, COVID patients' fatalities, in the sense that those we had about 3 patients in ICU for about 21 days, and they made it out of ICU and they were discharged home. We followed home, and they're quite well now, except that they have just been stigmatized by the surrounding neighborhood. That is all that I wanted to add. But in addition to that, I also want to share with the team that following my previous publications, the American Journal of Internal Medicine has selected me as one of their board members. Thank you.
That's really great, Mary, and really great in some of the cross collaboration, and especially having nurses on such boards is extremely important, and actually leads very well into the next category of questions, which is on how we collectively can push for nurses to be more in leadership settings. And maybe I'll start with Elizabeth, and if others want to add on this. There's one question that said, we hope the WHO will make it mandatory to have nurses at all high-level meetings moving forward. And then a separate question from Nancy that asked, I wonder what recommendations panelists have for challenging the organizational culture where our senior leadership in health generally frustrates those at the front lines. There's a disconnect between experiences of frontline nurses and management and those who were in management at the front line. While there are many nurses, sometimes there's a frustration or many issues. Sometimes the frustration is related to how managers communicate to those at the front line. Do you think, do the panelists think that there's communications interventions that have potential in improving relations between the senior leadership and the frontline nurses? And how would those communications interventions be implemented in a way that nurses feel heard and seen, and empathizes with the leadership pressures that nurse leaders, but also empathizes with the leadership pressures nurse leaders face? So maybe Elizabeth and others to those perspectives on both including nurses, including especially frontline voices in leadership meetings, and then ways of regular communication between frontline and nursing leaders, and greater recognition of the pressures that both frontline and nurse leaders face. Elizabeth, would you like to take on that one?
Yeah, this is really interesting because in another previous role, I was a chief nurse. I was, from a clinical experience. So I totally understand. But I think what's really important is when we talk about nursing leadership within countries, what does that actually mean? Does that title come with the responsibilities and the functions to enable the individual in that role to have the authority to utilize the best intel that they have within the organization to make those changes and to call on those key leaders within different departments to be a part of that that consultation or that policy discussion. I think that's really important to understand. And I know, we have, during the part of the State of the World's Nursing Report, we had identified that 70%, or just over 70% of countries had a chief nurse. But you have to, when you look at the extra data that's available, you have to kind of wonder whether they functioned with authority, with the responsibility of the role. That's really important. I think that then will impact on the communication strategy that's actually necessary to engage with those at the clinical level. I hope that's kind of...
Yeah, thank you. Barbara, would you like to add in?
Yes, thanks, Elizabeth. I agree with you absolutely, and I think the idea of leadership is so critical here. And I just want to introduce the idea that all of us are leaders in our own way, in our own position, and it's important to recognise that we can be the leader we can be today. And sometimes that means me going to the chief nurse and saying, I would like to talk to you. We have something to say. And I think we don't think of ourselves, and that's one of the things our survey found, we often don't think of ourselves as powerful, as having a voice. And that's to do often with the fact that we're women, not always, but I think, it's a more general issue for women, is finding our powerful voice. And a lot of nurses said they didn't feel able to give that kind of feedback. So if we're senior, I think, we need to be thinking to ourselves, how am I making sure that all the people who are working with me are telling me what I need to hear, speaking truth to power, as it were. But as a junior, you think, am I speaking truth to power? How can I do that? How can I express what I need, say what I want? And, some, like you, Elizabeth, you're a very enabling manager, but some of us aren't. And I think it's important to think, how do we enable people to have a voice? And how do we use our voice?
Thanks, Barbara. And I guess one more quick question while you're talking, Barbara, and then I'm gonna, the last theme, I think really very well transitions to some of our reflections from Candy Newman and Howard. But Barbara, there was a question of ongoing research initiatives on these issues and ways people can kind of get involved in that. And I know that Nursing Now is trying to continue to push on that front. So just wondering any comments on that question.
Yes, we're talking about the gender and leadership issue. Is it, Vince? Yeah.
I think just, yes, in general, yes.
In general.
Yeah.
We are, and in fact, we are looking a bit outside nursing as well to see what we can learn from people who are nurses, women leaders in other professions, in other situations, to see what we can learn. And there's a lot of work on nurses who are women. There's also a lot of work on nurses who are men, and we've been looking at that as well. One of the points that was raised in the chat boxes, which I think was very important, was that nurses often spend a lot of energy fighting each other. And I think one of the things Nursing Now has done at national level is to bring people together, to convene a platform where nurses can talk to each other. And I think we need to continue that. If we're not united as a profession, we don't look as professional as we might do. And we need everybody in nursing to be speaking, using data, influencing policy and politics. So we're really looking at how we continue that convening and how we can work with people who do research in women in leadership to really apply that to the nursing field. So that's what we're going to continue to do. And if people want to find out more about this, please write to me at Nursing Now.
Thanks, Barbara. And we will definitely, send those contacts along with the follow-up to this. And to your point of engaging other professions, that was a point that our friend Dr. Marilyn DeLuca made earlier in the chat, and also encouraged us to develop a global action plan on advancing nurses in leadership. And it's certainly something that I think some of the recommendations from the report that were released last year really kind of push to those lines. And I think we are very much interested, the collaboration with IntraHealth and Nursing Now, J&J, ICN, and others of continuing to push on this. So definitely colleagues who are interested in doing that, we certainly would like to keep pushing on that front. And so I'm going to hand it soon to Candy Newman, the Global Technical Lead for Gender Equality and Health at IntraHealth International, to provide some reflections. And as I do that, I'm just going to summarize a few of the comments that have been made, and I think a lot of the comments made in the chat today really reflect some of what we saw in the responses to the survey last year, saw in responses, the interviews that we conducted in Kenya in February, and things along the lines of issues of job security, not being able to speak out, the nurses have the same condition. Issue of visibility of nursing is common, that nursing is thought of as a second-class profession. Nursing leaders are to some extent afraid to engage the government, sometimes advocating for nurses and midwives. Leadership role is being tapped by other professionals, don't have formal recognition of nurses, and sometimes seen as worthless or helpless. A lot of comments along those lines, and Candy, as you reflect on what we've heard today, just wondering kind of how you see this moving forward, and especially amid the pandemic, and how we can, the gender transformative policies were mentioned by Dr. Nandili, kind of what we really need to try to focus all of this energy and collaboration that has been going on in nursing toward those gender transformative policies. So Candy, I will turn it to you now for your thoughts.
Thank you, Vince, and hello, everyone. I've been following these presentations very, very closely, and I'm struck by the fact that so many of the findings from the nursing study that IntraHealth and Nursing Now did last year, how many still pertain, are still alive, and how many of the gender issues have been exacerbated. I think that I was thinking of speaking on the impact of gender on nurse leadership, but I really think that what's come out today for me is the impact of COVID-19 on nurse leadership as well. I wanted to say one thing about this, not related to the nurse leadership study, but and Mary has already pointed this out, such as others have as well, and that is that as a female-dominated profession, there are special risk factors, hazards, and health problems that are associated with gender-segregated work, and in particular, the female-dominated profession of healthcare. There are the biological risks that are exacerbated during COVID-19. There are physical risks and hazards such as manual handling and strenuous postures. There are chemical hazards that frontline health workers and nurses face, cleaning, sterilizing, and disinfection. And there are also psychosocial risks and hazards that have been also brought out today that are associated with, in good times, shall we say, associated with the nature and structure of nursing work, emotionally demanding work, shift work, night work, the stress of balancing double burdens, sometimes triple burdens, home and paid work. And also, one of the things that has not come up in today's discussion, which is workplace violence and sexual harassment. It didn't come up, and maybe it is not happening, or maybe it's simply not being commented upon, but this is actually a problem for the nursing profession, and I'm throwing that out there because I was struck by the fact that it was not brought up. the exclusion of nurses and women from sites of power and decision-making, I was struck by the fact that people seem to be talking about different kinds of leadership, and there's a kind of policy-making and strategic leadership that perhaps nurses are not visible in, they are excluded from, but that especially in the case of the Chinese experience, it's really striking to see the level of clinical leadership that has been described. And also, when I read the paper that Linda and her colleagues have put together, it's also very, very striking, the level of collaboration between doctors and nurses and the sharing of responsibilities, which makes me kind of wonder whether there is something about COVID that disrupted patterns, rigid patterns of interaction that just didn't allow the kind of really productive collaboration that we saw described in that. But the point here is that there are strategic and policy kinds of venues that nurses seem to be excluded from. Also, the point that media don't seem to be picking up on nurse leadership in some cases, but although in other cases, again in China, that the media was showing illustrating the leadership of nurses as well as doctors. One thing that struck me also was this idea of nurses as heroes, nurses and doctors, health workers as heroes, but disturbing from Kenya is this observation that nurses are stigmatized for their role as close caregivers. This is an important thing, I think, that needs to be followed, researched, and addressed for the pandemic, but also in the long term. So rather than go through, how the nurse leadership study has been borne out or altered the findings, I just want to leave you because I'd like to give time to Howard to sort of sum up the way forward. But I think that I would love to have a discussion about the extent to which this pandemic has opened up, created disruptions in rigid patterns of exclusion and rigid and patterns of non-leadership, that it opens up, the disruptions open up a space for new kinds of leadership to be taken by nurses. So I think I'm going to stop there. Just wanted to point out only some of my observations, but give it over to Howard to bring us forward.
Thanks, Candy. And just transitioning to Howard Cadden, president of ICN, to close it out for today. And Howard, we asked the question in the title of our report last year of what will it take to really fully unlock the leadership potential of nursing. Obviously, we heard a lot today. In the midst of COVID, there's trillions that governments are pumping into the response. There's obviously a lot of energy here and energy for action. But yeah, we still see some of these barriers continue to stymie us. So just interested in hearing your reflections both on today and kind of how we act to make change in this area of nursing leadership. So over to you.
Vince, thank you very much, and thank you to not just to you, but to IntraHealth, to Nursing Now, to J&J. It's been fabulous to be partnering with you on this journey in relation to gender equality and leadership, and to participate into today. Just to be clear, I'm the CEO of ICN, not the president. Our president is Annette.
Sorry about that.
Kennedy. It's fine, but I thought you did it just to make sure that I was awake. But look, seriously, in terms of some reflections on what I've heard, the overwhelming majority of which that I agree with. First thing is, the data really matters. I remember earlier on in my career being very frustrated with, people who were always demanding to see the data and to see the evidence to back up your argument when you knew plainly something was wrong or something needed to change. The data is important, but the data is also a symptom of inequality. And let me just give you an example on this in relation to the COVID context. For those of you who haven't caught it, yesterday ICN put out its latest update in relation to healthcare worker infections from coronavirus and tragically the numbers of nurses who have died as a result of coronavirus. We now think that the number of health worker infections worldwide could be around the 450,000 mark. Tragically, the number of nurses that we're aware of who've died because of contracting coronavirus during the course of their work has exceeded 600. Nobody else is currently collecting that information in a systematic and standardized way. Some countries are, but they might be using different definitions. Others just aren't collecting it at all. And I think that is, that in itself, the fact that nobody is collecting that information in a systematic and a standardized way, speak volumes about some of the deep-rooted gender inequalities and inequities that we see. So the data is really important. It's the spotlight, the searchlight, that highlights what the problem may be. But the data isn't enough on its own. And let me carry on with my example from ICN's work yesterday, available on the website. I'd encourage you to look at it. When we then do some very simple analysis of the data that we have collected, we saw enormous variations in healthcare worker infections. Ireland, just this week, 30% of healthcare workers, they believe, have become infected, but then somewhere like Singapore with 1% or less of health worker infections, an enormous range. You see countries that are next door to each other, the USA and Canada, where in one country there may be around 100 nurses who've died as a result of coronavirus, their neighboring country, single digit, maybe 1, 2, or 3 nurses who have died. So the data is important, but then the analysis you do on the data really highlights again what some of the problems and issues might be. Having got the data, having done the analysis, then you can start to argue, to lobby, to advocate for what needs to be done about this. What are the recommendations? What are the policy changes that need to happen? And I think important just that we put those 3 bits of the jigsaw together. I think it's a very powerful case study in terms of what's happening now in relation to coronavirus that shows the relationship between inequality, data, analysis, and then recommendations for how we change for the future. And we need all 3 of them. Our future, and I'll come on to our future a bit in a moment, but I think those are 3 critical components. I was delighted to hear Elizabeth talk about the importance of the need for standardized and systematic collection of data as well. Let's just flip back to what's been said about leadership. And just on the data point about the leadership, as a number of speakers have mentioned, State of the World's Nursing Report, which ICN were very proud to co-chair along with Nursing Now and supporting WHO, identified 70% of the world's countries have chief nursing officers. First question from me, is that good enough? No. It should be 100%, and I don't know why we're not all saying that much more loudly and clearly that every country. Why wouldn't you? Why wouldn't you have a chief nursing officer? That's a question that I think that we should be posing more vocally and more strongly. But really important point, and Elizabeth touched on this. ICN did some work looking at chief nursing officers at the beginning of the year. Again, the brief is available on our website, and when we looked in more detail, out of those 70%, we found that some of those 70% might not actually be nurses. They may not have budgets or resources. They may not have staff. They may be positioned further down the hierarchy of an organization, so they don't really carry the weight and the authority as well. It's really important that when we have data to make arguments about what we want to see and what we want to see achieved, that we also are smart about following through some of that detail, because challenging observation, or perhaps this is a question, perhaps this would be, this has probably been set as an academic question by some. Would it be better to have a chief nursing officer and somebody who perhaps wasn't properly prepared and didn't have the resources and was able to fulfill that job fully? Would that be better, or would it be better not to have the job at all? I think that's something we need to think very carefully about. Could it actually be more harmful to us if we have positions that are positions in name own rather than positions which carry the full weight and authority? And then the other thing that I just wanted to pull out on the leadership point is we rightfully think and talk a lot about chief nursing officers, that's right, but let us not forget senior nursing leadership roles right the way down health systems and organizations. Do our hospitals, do our health organizations in our countries, the bodies leading public health, the bodies leading evidence or patient safety, are there chief nursing officers in all of those roles as well? And regrettably, I think that we don't see that. It's not just about the CNO position, it's about mainstreaming these senior nursing roles throughout healthcare systems. And a special plea for me is, do not forget, we should not forget the critical importance of the ward manager, ward sister, let's call it the middle manager nursing role. I think that that's often hugely underplayed. I've spent some time in industry. Bear with me just for 30 seconds on this before I was in nursing, and what I saw was private companies who invested huge amounts in the managers who oversaw the operation of their products on production lines, the people who sat between the production of the service, the delivery of the service, and then top level management. So these were people who looked down to the quality of what was being produced, but then reported that up to senior managers. Those people in industry are highly, highly, highly valued because they look both ways. And I think that in healthcare, it is commonly women who are in those roles, and those roles are not valued enough. So the leadership piece, think broadly about the leadership piece. And come back to another data from State of the World's Nursing, which again, I think really powerfully shows this as a symptom inequality in nursing. We've heard 59% of the workforce is our health workforce and nurses and midwives. How much of our education budget are we spending on 59% of the workforce? You'd have thought that it might be, you perhaps spend about 50%, around that figure of, on 59% of the workforce. No, we spend about 25%. That's a statistic which is in State of the World's Nursing report. Why are we only spending 25% on education and professional development budgets on 59% of the workforce, which our political leaders tell us are the backbone, the bedrock of our healthcare system? There are some really other powerful statistics in State of the World's Nursing report, which I'd encourage you to pull out and look at. Candace really importantly mentioned the issue of assaults, of violence. 25% of nurses reporting sexual harassment. We did some work just last week on assaults on healthcare workers as well. It is a major problem in the workplace. You need the data to really highlight just the magnitude of the problem. But again, once you've done that, say what the solution is. We want, where there are assaults, why aren't they being investigated? In the worst cases, why aren't criminal proceedings being instigated? Those are the conversations and the policy issues that you can lead into on the back of some of those recommendations. There are some really strong percentages as well in relation to lack of family-friendly policies, enabling nurses who are women to balance careers with childcare. I think it's a hugely important issue. Sometimes all of this stuff gets bundled into, oh, those are trade union issues. No, these are women's rights issues. These are rights of women at work, and we should not be ashamed, embarrassed about calling those out. Nurses' rights, women's rights are our human rights. I think the other thing that we need to be thinking about as well is where, and a number of speakers have talked about this, where our future generations of leaders are coming from. I've said that there isn't the resources in a fair way, I don't think, to support people. Barbara rightly touched on the mentorship issue and all of our roles, that we all have a responsibility to bring next generation forward. But I think that there's also something we need to unpick about what sort of leadership development we need. We spend a lot of time in nursing talking about or defending but the science of nursing, the decision making, the technical skills, the complex issues around autonomous practice as well, the importance of a degree, preparation, education. That is all absolutely right, and I'm not wishing to undermine the importance of that in any way, shape, or form. But equally, this is an observation, personal reflection on my time, particularly with ICN, what ICN do with our leadership development projects, which help people navigate complex health systems, the politics of healthcare, different organizations who you have to work with, how to advocate, how to make your case, how to be comfortable speaking in full public rooms on the media as well. These are really important skills that we should be thinking about investing in, as well as the clinical and the technical and the compassionate elements of nursing as well. So listen, those are some reflections in just some of the issues that have come up and some challenges about where we need to do more. But I just want to finish on a real message of hope and optimism. Pandemics change people, change societies, they change worlds. One of the things that this pandemic is doing is clearly showing how exposed and weak our health systems are, but it is also shining a light on inequality in the workforce, for women, for nurses, inequality in terms of people who are getting sick with coronavirus and in lower socioeconomic groups. The events of recent days in America following the death of George Floyd is clearly showing some of the chasms, not the inequality gaps, but some of the chasms and crevices of inequalities as well. The world is crying out for a new future, a new normal, whatever that is. I think nursing is perfectly positioned to be architects and designers of that. And I think our takeaway message is we need to create our own future. Don't ask permission. We need to take what we're hearing now, what Nursing Now, what Year of the Nurse is delivering, the State of the World's Nursing Report as a roadmap, and say, here is the future, here is the solution, and nursing is a major part of that. Vince, back to you.
Howard, that was amazing. Thank you so much, and thank you to all of us for sticking through with us. I think just to close, to say I know there are so many comments about how we kind of carry this forward. We will be sending around the link to the recording of this webinar. We will be sending out ways to continue to engage. I linked some of them in the chat here. ICN has policy recommendations. Nursing Now has ways to get engaged. The Frontline Health Workers Coalition that IntraHealth hosts a secretariat of has policy recommendations we're pushing the US government and we're pushing global institutions on. So please utilize your experience and your connections to continue to push on this. The issue of attacks on health workers, next week the Safeguarding Health and Conflict Coalition is going to release its annual report on attacks on health workers in conflict settings around the world, and some ways and recommendations for actions there. So there's plenty for us to act on, and we hope that you all will continue to stay engaged with us as we try to continue to push on these issues. And we thank all of you for your engagement and advocacy, and appreciate it, and hope everyone has a good morning, afternoon, evening. Thank you all so much for joining us.